Hey, this is Luke Maxfield. I'm a tutor with MedSchoolCoach. I tutor for USMLE 2, 3, and COMLEX 1, 2, and 3. We're going to take a look at a question today, just go through the vignette, look at some distinguishing features and a couple different diseases. So the second question here, an 8-year-old male is brought to his mother to the emergency department with a chief complaint of a rash. The review of systems is notable for arthralgias and abdominal pain. The physical exam reveals palpable, non-blanching violaceous papules and nodules, shown in the image provided. The laboratory examination reveals a complete blood count, CMP, urinalysis, all within normal limits, and what's the most appropriate treatment. So here again, we have a child, this time we're in the emergency department, looking at a rash, and then the two chief complaints or chief symptoms are arthralgias and abdominal pain. Then we have this very characteristic palpable violaceous rash. So anytime I see that an image is provided, I automatically open it up. In this case, we have these violaceous erythematous nodules and papules in the lower extremity, and then also on the extensor surface of the upper extremity. And these palpable, non-blanching violaceous lesions, the latter part of that being descriptive of purpura. So we have palpable purpura, and immediately in a childhood disease that should take you to Henoch-Shonlein Purpura. So now we have to know, what do we do with these patients? What's the most appropriate management treatment in these patients? So IV methylprednisolone. The use of corticosteroids is often controversial in a lot of disease states, but in Henoch-Shonlein Purpura, you'll also see it frequently used. And we need to understand what effect that actually has on the disease. But then we also, in addition to have IV methylprednisolone, we have the option of oral prednisone. So when you see oral and IV medications, the same medication with two different routes, really the only time you need the IV form is if the patient's too nauseous and can't tolerate medicines by mouth, or if the disease state is such that parenteral therapy is warranted. In this patient, we have a fairly well infant in all the ways abdominal pain. There's no evidence of vomiting. So it makes these two seem a little less likely since it's the same treatment in two forms. Next is cyclosporine. We know that that's a fairly harsh medication. It's immunosuppressant, and it can cause hypertension, among other things. Observation and oral methotrexate. So observation is always a really interesting one, and every time you see it on a question stem, it should make you at least think twice about it. Right now as a community, it seems like we're moving towards being more conservative with therapies and interventions. And so knowing when no treatment is appropriate is extremely important. And in this case, that is the most appropriate treatment, most appropriate next step in management. Those are all lead-ins for the same answer in this patient with Henoch-Shonlein Purpura. So what is HSP? So this is a small vessel IgA vasculitis. It can have multiple or different antecedent triggers, whether it's an infection or otherwise. But the reason that it's important is that this small vessel vasculitis involves the kidneys and the GI tract, but it has the risk to progress to chronic renal failure. It usually involves children younger than 10 years old in the winter and the fall, and the most common associated preceding illness is that of group A strep. And then it classically presents with this very unique triad of palpable purpura, arthralgias, and abdominal pain in pediatric patients. So the diagnosis is suspected clinically. Again, the features are very classic. And then once suspected, it's confirmed with a biopsy. You can either use the skin or the kidneys, and it demonstrates IgA deposition within endothelial cells and leukocytoclastic vasculitis. So one common area of confusion is that leukocytoclastic vasculitis is that it's synonymous with HSP. Leukocytoclastic vasculitis, or LCV, is actually a descriptive term, and it holds multiple diagnoses within it. It just refers to neutrophils, neutrophilic debris, or karyorrhexis, fibrin within the vessel walls, and extravasated red blood cells. But oftentimes, especially for step 1 and maybe even 2, if they'll use leukocytoclastic vasculitis and HSP, Henoch-Shonlein Purpura, a little synonymously for answer choices. So the treatment for uncomplicated HSP is observation with serial urinalysis. And if with urinalysis you see proteinuria, if you see on a CMP a decrease in estimated GFR, then the first line treatment for these children is ACE inhibitors. And it's important to know that in these patients, although you see them used in the real world, corticosteroids do not prevent renal disease. So if you have a patient with Henoch-Shonlein Purpura, the kidney function is fine. If you give them corticosteroids, it will not help prevent their renal disease. And if these patients develop renal disease, you treat them with ACE inhibitors, and they still progress, then renal transplantation may be required. Well, I hope this was useful for you. This gave you a couple of high-yield pediatric diseases where the diagnosis can be made clinically, and because of that, they're highly testable. See you next time.